I'm going to demonstrate a two-lobar technique of HoLEP. Our patient is 68-year-old male from Lakhimpur, Assam. He presented with us with a Foley catheter. He had a urinary symptoms for last 2 years, but did not take any uh, medical treatment for that, and slowly he went into urinary retention. The ultrasound said he had a prostate of 38 gram. So we begin with our cystoscopy. I'm Dr. BROJEN Barman, consultant urologist and kidney transplant surgeon. I work in Guwahati, Assam, and this is the cystoscopic finding. A lot of trabeculation in the bladder. So I'm starting my two-lobar technique of HoLEP surgery. I have a 550 nanometer micrometer fiber. I'm using a luminous HoLEP laser, and the settings are 2 joules and 35 frequency. So I begin elevating the left lobe from the floor of the prostate first. That's the first incision I make, and immediately I find my plane. This is the easiest part of the prostate to find the plane. And then as I continue with my surgery, I will gently incise the mucosa 1 or 2 mm at a time and elevate the prostatic lobe as well. Whenever I find that my elevating the prostatic adenoma is restricted, and I'll come back again and then further mobilize the adenoma from the floor of the prostate, and I will make my mucosal incision in the 5 o'clock position, more and more proximal, reaching to the bladder neck. So I am very close to the 12 o'clock now, and this is the strip of mucosa that I finally divide from the sphincter. So I am very close to the sphincter. I am not very inside or outside. At the very edge of the sphincter, we divide the mucosa. So it's not a big prostate, 38-gram prostate. Ultrasound, most of the time, they will overestimate the size of the prostate, and only rarely you'll find that they have actually underestimated the size of prostate. So my mucosal incision is almost completed. I have reached the bladder neck at the level of 12 o'clock position. I have connected both of my mucosal incision. There are some bleeders here that will often meet. These are arterial bleeders, and I'll come back to that in a while. Sometime it is very difficult, you can't see them properly. So once I'm able to see them properly, I will point coagulate them. So a very good plane is opening up. It's not a big prostate, small prostate. And so I have connected my 12 o'clock mucosal incision to the floor of the prostate, and it is easy from this point, and the capsular fiber are very well visualized. And here I have gone a little bit deeper in the 3 o'clock position, and I'm correcting my plane. I'm coming closer to my adenoma, and if I continue with my dissection in the same plane, the deeper plane which I have made, I would actually perforate my capsule. So coming back again in the 5 o'clock position, I will incise the mucosa now. So it's a true anatomic enucleation of the prostate, and I'm not cutting through the adenoma at any point of my time. I am enucleating the adenoma, and my dissection will be dictated by the shape of the adenoma. So this plane is quite easy to find. However, sometimes there may be very big lobe, the median lobe, which encroaches upon the boundary of the left lobe, and then it might come actually quite lateral. And so now it has become very easy. It is all about connecting the two plane. It is now, if you can visualize, it is now an U incision from the 5 o'clock position to the 2 o'clock, the 12 o'clock position. So as I proceed in the surgery, this U will progressively become a V incision, and then finally I will detach the adenoma from the bladder. So here I have changed the direction of my fiber. So my fiber is coming from the 12 o'clock now, and I changed my direction of the fiber at this position because it helps to avoid going subtrigonal in this region. These are some of the small bleeder. That's the bigger hole that I have made there. And at this point, when you convert your incision from a U to a V and separate the final attachment of the adenoma from the bladder neck, we come to the boundary and then gently separate the mucosa. And so I have pushed the adenoma in the bladder. My enucleation of the left lobe is complete. uh, Going through hemostatic part, if there are big bleeders, this is the sphincter well preserved. Now I'll focus my attention to the uh, adenoma on the right side as well as the median lobe. I made a transverse incision in the median lobe just proximal to the verumontanum, and this will be my plane of dissection, and I will dissect both the median lobe and the right lobe together, similar to what I did on the left side. I will incise the mucosa very close to the sphincter, 1 or 2 mm at a time. At the same time, I will elevate the adenoma from the floor of the prostate. So at the level of the verumontanum, the circle of mucosal incision will be very small. So you don't have to cut the mucosa in a long line if we do the true anatomical enucleation of the prostate. So I elevate the prostate from the floor whenever my further mucosal incision is restricted. I am in the 9-10 o'clock, and now I'll join this incision to the 12 o'clock position that I have already made in my previous part of the surgery. So only this mucosal strip is restricting any further mobilization, and I'm connecting this mucosal incision to the 12 o'clock mucosal incision, and here my fibers are almost, my laser fiber is almost horizontal. This part of the incision, we have to be as up as possible, and the uh, capsular fibers are more like a circular in arrangement at this location. So the nature of the capsular fibers are changing. At this location, when you cross the equatorial plane of the prostate, they appear more like cobweb. This is a bleeder, so I'll take care of that at this moment. And now the part of the surgery has become easy, and it's only a matter of turning my U incision to a V incision progressively. I will dissect the adenoma. I'm very close to my bladder neck now. So these are the few fibers that was connected to the adenoma. I'm doing my dissection under the roof of the prostate. As you can see, we have already reached the bladder neck. Here you will find some troublesome bleeding. Better to coagulate them at this point of this surgery. And yeah, there are a few of them. So the capsule of the prostate can be very well visualized here. And I have some dissection left. I have to dissect the adenoma from the hammock or the lateral wall of the prostate. And there is no pushing. The laser is cutting through the fibers. Here, I may have left a small adenoma. Let me probe it a little, and then nothing much. And I'm coming back to my median lobe and proceeding further. So during the two-lober technique, sometime we may actually leave a part of the median lobe. So it's very important that we dissect the median lobe from the 5 o'clock and 5 o'clock and connect this lateral plane to the medial plane of dissection. It's a small prostate comparatively, so such errors won't be common in small prostate, but in bigger prostate, it may be a big adenoma that we might actually leave behind in the medial lobe if we are doing a two lobe technique. These are some bleeders from the bladder neck. You can expect some bleeder here. Some will be bigger arteries. The arteries of maybe branches from the Badenoch's artery here, and at this point I would like to coagulate them because they would cause significant bleeding if I leave them behind. And there's a pulsating artery very close to the mucosa of the bladder. So my surgery is almost complete. At this point I'm relaxed. I have almost done the difficult job. It's only a matter of joining the two lines of the section and then removing or pushing the adenoma into the bladder. So at this point, sorry, at this point also one can go wrong because sometimes the adenoma actually goes into the inside the below and proximal to the bladder neck. Sometime here, as you can see, I'm very close. I can very easily make a mistake and then perforate at this area. So I'm change my direction of the laser fiber and cutting from above now, and I have gently negotiated across the potential area of subtrigonal dissection. So if we do a mistake, we can correct it. But if we continue in the same plane, we can actually enter the subtrigonal region. So I'm coming from the other side. Our U incision has already become a V. These are the last few attachment. And here we go. So the left lobe was enucleated first, then we enucleated the right lobe along with the median lobe. I will concentrate and do hemostasis if I find bigger bleeders and also the smaller potential bleeders. I will coagulate them at this point of time, and once a satisfactory hemostasis is achieved, I will start my morselation. There's some attachment, mucosal attachment here. So these are the fibers at the bladder neck. There are no big bleeders. This the fibers on the right side, capsular fiber, the spero, that's the well-preserved sphincter you can see. And I'll probe this area if some bleeders are hiding behind. And so no significant bleeder. There's a complete enucleation of the prostate, and we have not left any major bleeder uncoagulated. So this is the end of the enucleation. Uh, so two in the two in the two part of my dissection, I might actually have made a mistake. That was on the first in the left enucleation. I almost perforated my capsule. I corrected my plane again, and in the dissection of the right lobe also, I would have probably gone subtrigonal, but again we corrected our plane. These are some of the small bleeders in the mucosal margin of the veru. They may cause small bleeding, and better to coagulate the mucosal edges um, by the side of the veru. So I'm cutting short my morcellation part and only some morcellation also. So I'm using a VersaCut from Luminous, the same machine that I have been using for the last 5 years now. The blades have lost their uh, cutting sharpness, but still works well. They have been consistently giving me good result, and we're happy with its performance. So as you go through the morcellation, uh, the adenoma will become smaller in pieces. These are the cheese balls, sometimes very difficult, and if you persist, you might actually injure the mucosa. So if they're very adamant, we can actually take a loop, cut them into several sections. Once they are pliable, then you can yeah, you can pull them out through the loop. So I use two irrigation during my morcellation, and make sure that the bladder is distended throughout the procedure, because even though morcellation is a easy procedure and the surgeon is relaxed, but major complications can occur during the morcellation of the adenoma. Some mucosal cutting may be common, pulling out of the mucosal from the bladder, but major complication, including even perforations of the bladder, is not unknown. Injury to the ureteric orifice can occur. So these are troublesome cheese wall for me, and I'll try to remove them as much as possible without changing my instrument. And so let me see the ureteric orifice. Both the ureteric orifices are well preserved. The lens have become a little foggy at this point, and it's very adamant. Cheese balls, three of them left, and you can evacuate them also if they are smaller, and if they are bigger, there are some surgeon who will pull them into the prostatic fossa, and then they will morcellate them. Sometimes you have to do that as well. And reverse morcellation, I have not. I got stuck here a little bit, mucosal injury there. I'll take care of it later. Very small mucosal injury. Perhaps my bladder lost is this tension. So if you make a mucosal injury like that, it is important. I might have done it once again. So the bladder is not distended at this point of time, and let it distend for a while, and then I will start my morcellation again carefully. So if there's a mucosal injury like that, it is important to coagulate the edges of the mucosal injury in the final round of inspection. I usually do with a loop, and if there is any bleeder, I coagulate. So this is the final end. This is the sphincter, very well preserved sphincter. After HoLEP surgery, there's a lonely Veru appearance. You can see the Veru as well as the bladder neck and a well preserved sphincter. Thank you.